So it is our pleasure to open the 2012 National Summit. This year it's the National Summit on HIV and viral hepatitis, diagnosis, prevention, and access to care. And we'll just have a few introductory remarks, and then we'll go into our main speakers for the evening. So I'm just going to, as I said, make a few introductory remarks. First of all, I would like to thank all of our collaborating partners. The forum has taken on the task of organizing and convening the summit, but it is really a partnership with many organizations and many individuals that we have listed here. We also thank our supporters who have provided financial support so that we could hold this meeting and have people attend without having to spend all of their year's worth of conference travel on this one meeting. So the sponsorship is absolutely necessary and very much appreciated. And we're happy that this year we have such a wide array of sponsors that have contributed. I'd like to thank, of course, first of all, my two co-chairs, John Bartlett and Ken Mayer, whom you will hear from in a minute, but then also the whole organizing committee. This is the group that actually put the major part of the program together with input and advice from the scientific committee, but this is the group that sort of does the heavy lifting and puts the program together. And then we have a very extensive and amazing scientific advisory committee that helped us identify key questions to address speakers who contacted their own networks regarding this meeting so that we have all the abstracts and et cetera that we are basing this meeting on. And then also we really wanted to thank the category co-chairs. So we have four sort of main themes that run through the meeting. And for each category, we had an HIV person and a hepatitis person to help plan those particular sessions. So those breakout sessions are mostly abstract driven. So all of the abstracts that were submitted have contributed to this program. So thank you very much to all of them. I would like to also thank the forum staff who worked very, very hard. In particular, Ben Hauschild, and I'll ask him to just stand up very briefly. And he deserves a huge hand. He is the absolute summit master. And thank you, Ben, for all the work we've done. And also a short call out to Margie and Dave Poole. Dave is in the back there, Margie's in the speaking room. But Margie and Dave and the IHL staff have done an incredible job of getting us all here and making sure we have everything we need on site. And they're an absolute pleasure to work with. I wanted to say special thanks to Eddie, and you will see why when you see the performance tomorrow night by the Medea Project, and he really made this happen. And then very special welcomes to the 2012 Summit. We have a very special welcome for Secretary of Health and Human Services, Kathleen Sebelius, who will be joining us in a little while to give the keynote address. And we welcome Representative Henry A. Waxman, who will be here tomorrow to receive the third C. Everett Koop HIV/AIDS Public Health Leadership Award. And we also welcome Congresswoman Barbara Lee tomorrow, who will introduce the Medea Project, Rodessa Jones and the Medea Project, and will make a few remarks during the dinner tomorrow. So we have a lot of very special guests, and we welcome them all. So some of you may ask, why did we extend the summit to viral hepatitis? Isn't HIV enough? And certainly we've been busy enough in the previous summits. So the thinking was, and people came to us and said, why don't you consider doing it? We have two viral epidemics that affect significant proportions of the population. These two viral epidemics both are fed through the health disparities that we see throughout the nation. We do have two national a plan and a strategy, but they both kind of do the same thing. We do have sensitive specific tests for both, for hepatitis C and HIV. We do have antiviral and antiretroviral treatment so that if people are identified as infected, they can be treated successfully. These treatments provide individual and public health benefits. And there's a lot of public health synergies. And this is really a public health meeting. This meeting is about implementing the national HIV/AIDS strategy and the viral hepatitis plan. And so we thought, why not bring the two together And hopefully this experiment will work, certainly based on the abstracts that we have received and everything. I think this will be an extremely good program, but we look forward to hearing back from you regarding how well this merging of the two topics has been. And I'm just going to show this one slide that I'm sure you've all seen. And basically, in 2007, the mortality rate associated with HCV infections surpassed that from HIV infections, and you can see the point of where that happens right there on the slide. And this is taken from the paper by Lee et al. In Annals of Internal Medicine. And what we usually do at the opening is we sort of take count, okay, what has happened since the last time we met? Well, we have Obamacare, we have the Viral Hepatitis Action Plan, we have new treatments approved, direct-acting antivirals for hepatitis C, we have HPTN 052, and I think everybody knows what that means. It means treatment reduces transmission. We have one PrEP protocol approved. And we have revised USPSTF recommendations both for HIV screening and for hepatitis C screening. So when we think then about bridging HIV and HCV and the science, so with HIV we have diverse testing platforms and modalities. We have targeted testing. We know that targeted testing misses a lot of folks. That's why we have those 2006 recommendations, and that's been proven over and over again. We've seen many studies, many programs, where if the testing truly is routine, people will get tested, but it has to be truly routine. We can provide lifelong viral suppression, and if we decrease the virus, we decrease transmission. So what does it look like for hepatitis C? Very much the same. We have not as many, but diverse testing platforms and modalities. We know that targeted testing has missed folks. That's why so many folks are not identified. And we assume that folks will get tested if it becomes routine. And we can cure. We can actually cure hepatitis C, so it's different from HIV. So the question is, will eliminating the virus then eliminate transmission? And I think we would all say yes, and we certainly hope we will not be required to do a randomized blinded study to demonstrate that. So in terms then of bridging HIV and HCV programs, there are lots of synergies, opportunities for collaboration, efficiencies and cost and resources. And what we will be hearing a lot about today is the Affordable Care Act and how the implementation of that will help us reach our goals. And so, where are we today? How far have we come? What is the action plan moving forward? These are the questions. The last question is what we want to know by the end of Wednesday noon. How do we unite the promise of research and the reality of implementation? So let's get to work. And with that, I will welcome Ken Mayer to give a brief presentation.
Thanks, Veronica. Good afternoon, everyone. First of all, I just want to congratulate Veronica and the staff of the forum for putting together another very exciting, comprehensive, and important meeting. And we're having a little audio-visual thing here. There we go. Okay. So, welcome to the summit. My wish list in terms of the issues that we need to think about over the next couple of days, in addition to some of the things that Veronica mentioned, is this is the first summit that's happened since the re-election of the president. And I think we're very fortunate now to, A, know that the Affordable Care Act will be implemented, and B, that there's an administration that already has been working hard on a national AIDS strategy. So really the question for us is, how do we use the current new tools available to us to optimally contain the U.S. HIV epidemic? We have a bunch of different interventions now based on antiretroviral therapy as a mainstay for prevention. But in addition to the implementation issues raised by HPTN 052, just how do we get enough people tested to know that they're infected to start on treatment? Another important take-home from HPTN 052 was that even in this study where couples both signed informed consent, there were a substantial number of extraspousal infections. So test and treat will not protect HIV uninfected people if they're having outside relationships. So one of the big questions for us over the next few years is, to what extent is implementation of pre-exposure prophylaxis a relevant part of this public health strategy? And although there have been variable results in the PrEP studies, the key unifying theme was that if people take the pills, they can work. Again, another challenge for us in terms of how do we best use limited resources if we're trying to address the U.S. HIV epidemic. There's been a lot of attention on the cascade, and although we have focused in past summits very much on how do we identify the 200,000 plus people who are HIV infected in the U.S. and unaware of their infection, and how do we decrease the number of new infections from 50,000 or so a year to a smaller number, we really have to focus in the middle of the cascade much more about how do we engage people in care once they're tested, to stay stably in care, and then to initiate earlier initiation of antiretroviral therapy in order to have an effect in terms of decreasing the number of people who might be infectious to others in the country. There's been the ECHIP program, the Expanded Comprehensive HIV Prevention Program, that is focused on 12 jurisdictions. And we can talk about the U.S. epidemic as a series of micro-epidemics in different communities. But now's the time really where we have to drill down and figure out what are the best strategies to rule out all the different prevention opportunities in the different communities around the country. Just recently at the International AIDS Conference, a study that I participated in, HP 10061, 6-city data about more than 1,500 young black MSM, older black MSM. We found that among the younger MSM, the HIV incidence rates were almost 6% per year. So clearly, our current technologies and strategies have been failing us if we're seeing these kinds of rates of infection in the United States when we do have so many opportunities available to us. Yet at the same time, we are seeing some signs of hope. There were data presented several years ago about decreasing epidemic in San Francisco. These are data from Massachusetts. What we don't know from this ecological experiment is to what extent can we credit early initiation of health reform, to what extent is the characteristics of the community in the state, to what extent were structural interventions like early initiation of needle exchange and marriage equality, to what extent are these having appreciable effects on the epidemic, but we are seeing a secular trend towards a decreasing number of new infections. So we have to learn from places that may be successful and try to delineate what are the issues that can be replicated in the rest of the country. So here's my wish list in terms of what I'd like to know over the next few days: how we can best expand testing and linkage to care and retention, how we can roll out self-testing as an increased way to help people know their serostatus. Is there a role for PrEP and how this becomes part of a prevention package? The optimal behavioral interventions to enhance medication adherence, to decrease risk-taking, and what's the ultimate impact of the Affordable Care Act and how this will ultimately affect AIDS care, and this plus the reauthorization of Ryan White. What is the future of financing and the care of people living with HIV looking like in an era of health reform? With that, I'd like to turn the podium over to my colleague, Dr. John Bartlett of Johns Hopkins University. Thank you.
Hi, everyone. So I'm not going to present slides because I figured those two guys would say everything I was going to say. So what I'm going to say is just a few things about this meeting and sort of why it's a special meeting. This is really a moment in time, an Academy Award part of disease. And the people that are in the room are the parts of it that bring it all together, and it's the only meeting that actually does that I know of. So let me mention, first of all, the priorities. The priorities for HIV infection are to get rid of it, and for hepatitis C is to get rid of it. So we're hoping to make these endangered species, and that's the goal. In terms of the players that got us there, because if you've had a history with these diseases, you know what the history is, and it is so painful. But in terms of the players, I think there are 5 to call attention to. One is the science of it, and I sort of think if you had to single out one person that was really important in all of this, it would be Tony Fauci. who got goosebumps when he read that MMWR in July, not the June one, the July one. And it changed his whole career from Waldenstrom's macroglobulinemia to HIV. Thank God for the goosebumps. And he said he never had goosebumps before. He actually called them goose pimples, but that's not right. And he's never had them since. But of course, he led the machine that produced such incredible science by an extraordinary group of investigators. And then the second would be industry. Industry took a lot of chances with this disease. I mean, who could ever imagine being able to treat a retrovirus, a virus that's inculcated into the gene of a human? And so AZT was a total shock in 1985. I mean, just nobody expected this. And thank goodness for Jeff Murray at the FDA, who saw this and became a facilitator for the pipeline of new drugs. And it's the same with hepatitis C. I haven't looked recently. I looked about 10 minutes ago at the website. There are now 34 drugs in phase 2 or 3 for hepatitis C. I mean, that's just, you know, there's less than 3 antibiotics. And that's what hepatitis, I'm serious. And that's what hepatitis has in their portfolio now. And of course, a lot of it was because of AIDS. So that would be the second, the industry. And the third is the providers. The providers of HIV are kind of a small group. It makes up 1% of the physician pie in the United States, with an extended family that you all know about. We talk to each other, and we have our meetings and our magazines, our journals, and so forth. We don't reach out to many people outside of our little circle very well or very often, but they do. The group does a very good job and is very committed. Thank God for that team. The fourth would be why these two diseases are different. These are both chronic diseases that kill. They're both diseases that selectively attack poor people. The rate of AIDS in people below the poverty line is as great as it is in Africa. It's an amazing selection that none of us really understand. It's probably the same in hepatitis C as well. And it's two bugs that we seek to destroy. And don't forget, we have that heritage. Smallpox is gone. Polio is 99.9% gone, and guinea worm is 99.99% gone. And now, of course, Hillary Clinton has said there should be an AIDS-free generation. And we're all thinking that that's going to be a reality, not for a long time, but nevertheless a realistic expectation. And then finally, number 5 would be the people that own it. And I would say the people that own it are probably the people that pay for it and regulate it, like all of medicine. And that's tough, and we're about to do this transition to healthcare reform. Now, I work in a clinic, the Moore Clinic, and we recently did the analysis of 6,000 patients, inner city Baltimore, 85% below the poverty line, 77% African American, 45% injection drug users. Average patient in that clinic is expected to live to be 73.2 years old. So how do you get there? I can tell you the only way we can get there is with Ryan White Care Act. We depend on Ryan White Care Act. So I'm going to finish with a few questions that Ken had questions at the end of his. I think none of us really know what's going to happen with the healthcare reform. I don't know what's going to happen to the Moore Clinic. I don't know if it'll be there. I don't know what's going to happen to Ryan White. I don't know if it's going to be there. I don't know what's going to happen to the STD clinics in Baltimore. God have those clinics. So there's a lot of parts of this that are really critical as we move forward. And that's why I started by saying this is a really important meeting. And it's an important meeting in part because all of the players in the 5 different pieces are here. And the whole cascade of care seems to be on the brink of change in some major way. And one of the things I dearly hope to achieve at this meeting is to find out the answers to those 4 questions that I asked. I'll finish there and thank you.